Hi, my name is Jessica Ebner, and today I will be discussing hypertension on my PowerPoint presentation. There are three types of hypertension that we see in primary care: essential, secondary, and isolated systolic hypertension. We often see isolated systolic hypertension in our geriatric population. Although only the top number, the systolic number, is elevated, it's still very important to treat, as this is a significant predictor of cardiovascular disease in our older adults, as well as younger populations that also have ISH. Secondary causes of hypertension can be several things, such as obstructive sleep apnea, primary aldosteronism, renal vascular disease, drug or alcohol related, coarctation of the aorta. There could be thyroid or parathyroid disease going on, and Cushing's syndrome. These are all various reasons as to why a patient can have hypertension. In order to treat secondary hypertension, we want to find the root cause, treat that if possible, and from there we manage the blood pressure. The new guidelines that we follow, the JNC 8 guidelines, have a few changes from JNC 7. Age now matters for hypertensive labeling and for initiating pharmaceutical therapy. If the patient is less than 60 years old, the evidence-based guidelines recommend 140/90. If the patient is 60 or greater, the evidence-based research, which the JNC 8 guideline goes off of, recommends 150/90. In a patient that has diabetes or chronic kidney disease, they do recommend the 140/90 blood pressure, as this will provide better chronic disease management and decrease the already elevated risk factor for cardiovascular disease. It is very important to screen for hypertension, and according to the United States Preventive Service Task Force, as of their 2019 recommendations, adults between the ages of 18 and 39 years old who lack other risk factors such as diabetes, smoking, significant family history, etc., those people should be screened every 3 to 5 years. There is a recommendation for adults to be screened every single year if they are over the age of 40 and have additional risk factors. These additional risk factors, besides the ones I just mentioned, are obesity and the African American race. Additionally, the USPSTF recommendations as of 2019 recommend annual screening with the OBGYN population, and this is also according to the American Congress of Obstetrics and Gynecologists. Screening for hypertension is not only cost effective, it is a substantial net benefit, and it's harmless to screen for. Hypertension is one of the most important preventable contributors to disease and death in the U.S. Hypertension is also one of the leading causes for patients having an MI, stroke, or renal disease. Additionally, hypertension is a symptom of renal disease if renal disease is existing first. It is not only important to avoid hypertension in that population, but it's also important to control it as a side effect of the CKD. Some goals that we want to focus on after we diagnose hypertension include assessing target end organ disease. This not only is cardiac related, this damage due to uncontrolled hypertension can affect the eyes, the kidneys, the brain, and of course the heart and blood vessels. This is why it's very important for patients who have high blood pressure to have regular eye exams and regular blood work in order to monitor the kidney function as well. Additionally, it's important to assess for cardiovascular risk factors. These include having additional comorbidities such as diabetes, being a smoker, living an unhealthy lifestyle with poor dietary habits, and living a sedentary lifestyle. If a patient has known high cholesterol or a premature family history of peripheral vascular disease, we also want to take a closer look at those patients. This is because all of the risk factors that I mentioned elevate the 10-year atherosclerotic cardiovascular disease risk. There are several lifestyle modifications, pharmacologic treatments that can help lower this risk. Many patients are unaware that all of these factors together are raising their 10-year risk and their lifetime risk of having a cardiovascular event to be quite significant. Two other points I'd like to mention for goals after hypertensive diagnosis is to keep reviewing the psychosocial stressors that a patient may be going through, seeing, if there is a time in their life when they're very stressed out and their high blood pressure is out of control. It's important to educate the patient to develop some better coping mechanisms and relieve some stress, as this isn't going to help their hypertensive issue. If a secondary cause of hypertension is not initially found, when it is found, it is vital to treat that. I thought this was an interesting picture to include in my PowerPoint, as this is an up close and personal picture of the eye, the cup and the disc, and you can see some of the flame hemorrhages, some of the fatty deposit exudates, and some cotton wool spots. Those are like microvascular stroke indications that all three of these are a result of uncontrolled hypertension that are affecting the microvascular portions of the eyes. So in addition to the fundoscopic eye examination, these patients who have the blood pressure and uncontrolled blood pressure, they also need to have their BMI calculated. Sometimes it's an eye-opener for patients to understand what the BMI means and what their BMI correlates to, as this can motivate them to change their lifestyle habits and realize the repercussions of what their weight is doing for their overall health. Other assessment strategies that we need to focus on primarily for, or additionally for our hypertensive patients, is the heart examination, the lung examination, thyroid, as we know this can be a secondary cause. We want to auscultate for any bruits. We want to examine the lower extremities, and we want to always be doing neurological assessments. When we're doing our lung examination, we're looking for signs of congestive heart failure, such as crackles or diminished breath sounds. CHF can happen if there's long-standing uncontrolled hypertension, although this is usually over many years. The reason that we're looking at the lower extremities, we're looking for signs of peripheral vascular disease, and these can include diminished pulses and loss of extremity hair. We're also assessing the thyroid because we want to be aware of any nodules or masses that are found and any thyromegaly that could indicate hyperthyroidism. After we diagnose hypertension, it is very, very important to do routine blood work, monitoring to measure various things that can further increase the cardiovascular risk. A lipid profile is essential. This not only assesses the good cholesterol, the HDLs, but also measures the bad cholesterol, the LDLs, and the triglycerides. As patients change their lifestyle habits in terms of diet and exercise, and perhaps start a lipid-lowering agent, we can see these drop down, and also we can correlate that with a decreased risk of an event within the next 10 years. It's important to do a basic metabolic panel, as this will show if there is elevated fasting blood glucose. This isn't just looking for patients who have diabetes, but also looking for impaired fasting glucose, which is when a patient's hemoglobin A1C is between 5.7 and 6.4. When a patient's at this point, it is very important to educate them that they're considered pre-diabetic, and this can additionally harm their overall outlook on their health in addition to the hypertensive diagnosis. It is important to assess the potassium because several of these blood pressure medications, especially the ACE and the ARBs, can cause hyperkalemia. Also, some of the diuretics may cause hypokalemia, so this is very important to assess in all patients regularly with blood work. Additionally, diuretics can cause can cause the hypokalemia. A baseline potassium can help determine any antihypertensive therapy that needs to be adjusted. Baseline sodium is also important to evaluate any changes and educate the patient on the importance of salt restriction. We will also be evaluating serum creatinine, or the corresponding low estimated GFR. This can indicate the end organ damage of the kidneys, hypertensive nephropathy. This occurs as a result of long-term uncontrolled hypertension. Some blood pressure meds that can elevate the creatinine are also the ACE, ARBs, and the diuretics. We assess also the serum calcium because we're evaluating for primary hyperparathyroidism. As we know, this can be a secondary cause of hypertension, so this is important to rule out. TSH screening for hypo and hyperthyroidism is also routinely done. A urine analysis is often performed to evaluate for proteinuria and which can be evidence to prove that there is hypertensive nephropathy occurring. Urine analysis is also done for diabetics, but it is equally as important for patients who have hypertension, as there is measurement of urinary albumin excretion and the albumin-creatinine ratio. The American College of Cardiology and the American Heart Association guidelines recommend weight loss for those who are overweight or obese. This is based on the BMI. A heart-healthy diet like the DASH eating plan, a sodium restricted diet, and potassium supplement through food, increased physical activity, and a limitation of alcohol can greatly improve the overall outlook for these patients. It is imperative to educate the patient on the various methods to stay motivated, to successfully change their lifestyle habits, and to quit smoking. Smoking cessation can be through behavioral and pharmacologic methods. This is a patient preference. It is also important to educate them to avoid secondhand smoke. These changes will dramatically reduce the cardiovascular risk, but further lifestyle modifications can be made, including moderate to rigorous physical activity. The systolic blood pressure will drop approximately one number per kilogram of weight lost. This is a very motivating factor to tell patients